demonstration of perfect refractive solution, part 2. And our first speaker is Dr. Anand from Coimbatore. He will be talking regarding why triphobic. I will learn.
So, good afternoon, everyone. Good afternoon, everyone. At the outset, I would like to thank Care Group and Ratish for this opportunity. Why triphobic, the true trifocal? So, no financial disclosures. Our center, we are known for high volume phaco-refractive surgeries and glass-free centers, we are called. So, we were doing a lot of multifocals. So, as soon as trifocals were launched, so trifocal has become part of our practice. Whenever a non-cataractous or ametropic patients or with mild ametropia, he enjoys a very good range of vision because of his natural crystalline lenses. When the same patient comes back to us with a cataract or for refractive lens exchange to become glass independent, I always feel surgeons' IOL should be a personalized approach. It's not a one size fit which suits all the people, so we need to understand the need of the patients and we should be aware of the physics of each and every IOL. There are so many options available. So laser based corrections do not give a promising result, so earlier multifocal is almost outdated these days. It's between the trifocal and the EDOF lenses. Multifocals ruled the industry for 10 years, but lack of intermediate vision is one of the main failures, and this was a phenomenon we couldn't overcome with the multifocals. The trifocals haptives have improved better. It has improved in such a way that there is very little drop off between the points in trifocal IOLs. ADOF have developed along with the trifocals, but I could see that with that of near vision is compromised even after bilateral implantations. And since we're increasing the range of focus in ADOF lenses, there could be dysphotopsias, especially in the dim light conditions. The ideal patients for trifocal is it should be desirous to become glass independent. No other comorbidities, even moderate to severe dry eye, should not be there. Preferably, ametropic or hyperopic cataract patients or very minimal myopic patients are ideal for these patients. Lens pathologies, subluxations, pseudoexfoliation, I prefer not to do. Along with these indications, if patient is above 80 years, I don't want to take away pseudochoronative effect. If is having pre-existing against the rule astigmatism, I don't prefer to put trifocals. So triphobic, the true IOL, is also my preferred choice. You see here, it has all the good properties of what a trifocal should have. It's a hydrophobic lens. It is negative aspheric, and see the refractive index, it's 1.53. It is a apodized lens. It is a combination of plus 3.5 near, one for far and intermediate, plus 1.8. Let us understand one by one. Asphericity is very, very important because asphericity means we know that the power remains constant even at the center as well as the periphery, and it gives the same focus for both central and the peripheral. This has got on minus 0.15 as I mentioned. Whenever the lens has got a aspheric surface, it always gives the pseudo accommodative effect. It improves the contrast, and it is ideal for the young cataractus patients. Apodization was the same concept when multifocals came in, where the step heights are reduced from center to the periphery. Here in trifocal, what they have done is there is a near addition of plus 3.5, which helps for distance and the near. It's completely diffractive lens, there is no refractive component, and for intermediate, there is plus 1.8. These two are combined in such a way the apodization, the height reduces, but the angulation increases from center to the periphery. The dynamic energy transfer, what the technology incorporated into this, will help the lens, even though it is asymmetric, to have an appropriate distribution for the far, intermediate, and the near. That's why this is called as true. And it has got a square edge design which helps to prevent the PCF formation. And because of the dynamic energy transfer, this thing scattering of light is very, very minimal with this triphobic lenses. This is very important. The total amount of light loss is literally less than 10%. And this is the asymmetry was mentioning. For distance around 50, intermediate and near it's around 20%. Defocus curve, we know it's a measure to see the IOL performances. We could see that triphobic lenses, they perform very well at good range of vision. And whenever the Abbe number is more, the chromatic aberrations is reduced. Whenever refractive index is around 1.5 to 1.3, the chromatic aberrations are well controlled. So contrast is better with these lenses. In my experience, I think routinely we practice triphobic IOLs because implantation of lenses may be easy, but handling the complicated patient is very, very difficult. Since these lenses are excellent, so this has become a routine part of our practice. So in our follow-up, I could see that the majority of the patients do well better than 6.9 with bilateral implantation. They do until 6.6. The most important thing is about their intermediate vision. They are very comfortable reading their tabs or mobiles between 70 to 80 centimeters. The reading speed almost 150 to 180 words they could read per minute. Since we target ametropia, all the patients maintained within plus or minus 0.5. This is most important. There were no such annoying patients that they were so much disturbed with the disorder phenomenon of the trifocal IOLs that I never means what we could see in the days of multifocal. I don't want this trifocal lens inside. So annoying symptoms were negligible in this set of patients. So I could achieve what I wanted in my patients, except for 5 to 10% of the people they wanted to use at least +1 for very minute objects. So along with good IOL, other mandatory criteria is you should target ametropia, preferably use Barrett Universal 2, have a good rexis of 5 to 5.5. Surgical maneuvers should be very, very minimal. Good cortical cleanup, place always IOL in the back, do a thorough visco wash. So trifocal implantation can be performed by the surgeon who is aware of the principles of refractive surgery, and triphobic gives the excellent result for distance independent ear with very minimal dysphotopsic phenomenon. Thank you.
And one thing, very nice talk you have given. One thing I want to add that in refractive lens exchange patient, most of the patient are younger and the high myopic category. The range of power available with the range is more than the what the other company provides.
Yes, sir, right,
Yeah,
yes,
in the Alcon use of +6 to 30. In either side, they are going much beyond to giving the full vision. So the problem occurs with those lenses if we need a +3 kind of power in the patient, then it's become difficult to choose this trifocal lens. And the other thing regarding the near vision problem you talked about, is common with every lens
yes.
in few patient, and it is really comparable to other lenses.
No,
so
no,
not
yeah.
some people coming, this patient has a near vision problem. You can even see panoptics you are putting, they are near vision problem in few patients. So it is, the result is comparable. So what other advantages you feel in implantation?
With the triphobic compared to other trifocals?
Yes.
To be frank enough, I think I use more of trifocals in my practice. Cost is one factor. And being an Indian company, it is, as you told, the range of this thing is easily accessible. If you look into our results, see, we are sitting in a very prime center in a big city where patients do not expect that they again become independent. So we choose the patients properly. I have mentioned that only 6% of the patient, with bilateral implantations, N8 and better is almost there with these patients. Sometimes too much letters they read. I remember one or two patients telling that I read the little horoscope on the paper. Only those sort of times. That too, I've given them +1, not more than that for occasional use. Otherwise, most of the times with bilateral implantations, they do pretty very well. More than the vision, we were bothered about the dysphotopsic phenomenon. I've made patients to drive. They come back and tell that yes, I'm very comfortable. You can proceed with the other eye. So that's most promising. Vision-wise, I think N8 and better will always do good for elderly people.
Anybody want to ask any question? I will 1 minute to.
This is also trifocal lens. That's it on the box. And this is also hydrophobic trifocal. What is the basic difference between both?
I think company guys should answer this. Same thing I had asked them. So.
Actually, that was the lens launched 10 years back, and that was a lens at that time of maybe it was giving a bifocality along with some extent of intermediate vision. That was pupil dependent. But once the technology evolved, the trifocal actually came, and which was actually independent of pupil thing, and the entire range of vision near, far, and intermediate was possible. So this is a tradition.
It's a generation gap between
Yes.
a trifocal and a accretive platform. So
This is purely
trifobic is a upgraded version.
Upgraded.
Thank you,
Same
Doctor.
question I had when I saw the box initial days of triphobic. Yeah.
Thank you, Dr. Anand.
Yes, sir.
Now I would like to call Dr. Parkhyat Dhruv, who is talking about new revolutionary technology Z8.
Thank you so much, sir. While I set up, I'll introduce this new workhorse that we have got with us now, which is the Zeemer Z8. So this is the latest model of the femtosecond laser that this company is marketed for so long, and it's a very unique femtosecond laser because no other company has ever tried to even match the spot size or the low energy laser technology that these Zeemer technology machines have. So I'll right away jump into it. Now, the Zeemer Z8 is a true workhorse because it gives you everything that a femtosecond laser can do in one machine. So it saves you OT space, it saves you money, and it does everything, and it does it excellently well. We have the lenticule extraction, which is the latest development in lenticule extraction technology, which is clear. Then we have the femtosecond laser for cataract, which works exceedingly well. We have the Z LASIK, for which Zeemer is famous for a very, very long time. They have the smoothest flap in the world, and it's very well known the world over, so I'll not be getting much into it. And then we also have the keratoplasty platform, and the keratoplasty module has also been there for a long time, and Zeemer is the only machine that has such a wide variety of applications for keratoplasty. I am a consultant to Zeemer on clear technology, and I've been doing some research work for them. So I'll be speaking on the concept of low energy femtosecond laser because it is so important to know the difference between all the other femtosecond lasers and how Zeemer works to understand why it is beneficial. And then we'll talk about clear and cataract surgery. I'll briefly touch on what is in store for future. So if you look at the low energy laser, it is a continuous overlapping spot of a very small size 1/100th of what any other femtosecond laser machine delivers, and it is continuous overlapping spot rather than having space of corneal bridges in between. It is a continuous spot, and if you compare it to any conventional femtosecond laser, you don't have any tissue bridges in between. Now, so how does that help you? So in corneal lenticule extraction for advanced refractive surgery, that is clear. Let's first have a look at the interface, and then we'll discuss how it's different. So basically, this is how you mark. I've put my corneal marks, which I do with the GV pen on the slit lamp, and then I dock the patient on the machine. The machine allows me to center on the visual axis based on these marks. I can also correct for cyclotorsion based on these marks. I can correct up to -10 of cylinder, which is a very big boon because astigmatism is something which was not very well corrected in lenticule extraction. And then I get a real-time OCT picture of where exactly my incision is going to be placed. So this is a real-time image. I can know that this is where my incision is going to be placed. If it is correct, I can proceed. Otherwise, I can change the position of the lenticule. And then the cut goes on from the periphery to the center, and it has a venting channel for the excessive production of opaque bubbles which can be vented out, and they don't remain in the interface. So it gives you a very, very smooth interface. And once the procedure is done, it takes a post OCT just for your own sake, and this is how you proceed further. Now let's talk about how well the energy is optimized in this technology. You see, in any other laser, there is a constant setting for energy spot, and that will be delivered from the periphery to the center, anterior and posterior both. This is the only machine that has customized the energy distribution delivered into the cornea as per the depth. So for example, I'll make it simple for everyone. For example, we are cutting the posterior surface, which is the refractive surface of, which is the surface that is curved and is going to do the refractive correction in the lenticule. And we are delivering an energy which is equivalent to 40% of the maximum, right from the periphery till the center. And so, if you come to think of it, there is a huge difference in depth of the cut at the periphery as compared to the center in the lenticule cut. If I deliver equal amount of energy to all the whole depth of the cornea, then at least somewhere I am delivering excessive energy. This is what the customization of energy is. So what they did is they customized the energy delivered to the cornea based on the depth at which it will be delivered, so that it does the job, but it is not an overkill. So what happens is that the energy goes on increasing as you go from the periphery to the center. So you are delivering much lesser energy in the periphery where the cut is more superficial, and as you go deeper, the energy goes on increasing. Now what that does is that gives you a very, very, very smooth interface. There is excessive energy is eliminated, and you're getting exactly the amount of energy that is required to produce a very smooth cut, which can be dissected very easily. And I'll show it to you here. So this is how the microscope looks like. We have to attach our own microscope, which is another freedom that I feel is a very personal preference. Anybody can use whatever optics they like. So this is how the interface looks like. This is the cap cut that I am going to dissect first, and then we'll move to the lenticule cut. And you can see that my spatula or the dissector passes very smoothly, and then I go into the posterior plane and I can easily sweep it. It is completely separated. I just have to just take it out by just sliding my instrument and just removing the sticky part of the stroma. Basically, just the hydrophobicity of the stroma is holding the lenticule inside. I can actually remove it out just by flushing it with fluid. So this is the posterior, and I can easily slide my instrument, and there's no problem of any tags, no problem of suction losses, no problem of attached black spots, segments, things like that. It's easy, and the eye looks pristine as before. And the best part about this is that I have never had a problem in doing the surgical maneuver of taking out the lenticule. That is the best thing about it. With the energy optimized trajectories, we are achieving up to 90% patients at BCVA on day 1. So 90% of the patients are 6x6 on day 1. And by 1 week, it is up to 99% or so. And higher order abrasions are much lesser than any other lenticule extraction platform. So it is a very, very good tool, and I'm really happy with it. Coming to the cataract in Z8. So it is a very, very unique platform in the sense that it delivers excellent centration. It is a liquid lens interface, so the IOP doesn't rise. And then you get a very, very good and intact, strong capsular axis. The reason is that once you do the rhexis in a femtosecond laser machine, you realize that because of the missing spots in between, you get tags of capsule, and when you do a hydrodissection, there is always a risk of it opening up. In this, you don't have that risk. The second thing is it has a very good arcuate incision. So if you see the LRIs, then the LRIs are very predictable and extremely precise in depth. This machine takes 3 scans at the meridians of the LRI that you have planned, and it will show you on a real-time OCT what is the depth of the LRI. You can customize it to your own needs, and then once you do the start the laser, you can see that it will give you a real-time picture and the OCT scan after every step of the procedure, and you can bypass any step, skip any step if you want at any time. So I do all the things. I do the incisions, I do the capsulotomy, nucleotomy, and the LRIs in all my cases, and it always works extremely well. And I will show you so you can see that I've opened my side port and I inject intracameral anesthetic, which I always do in all my cases. And then I open the main incision with my incision opener, and you can see that it easily slides in and opens. The capsule is always free. The CCC is always a free floating rhexis, and you can just take it out. And I'll do a hydro without having any fear that the rhexis might give way and I'll have an anterior capsule tear, which used to be very common with the previous platform that I was using, which was LensX. And then you go in and you see that the nucleotomy is already very well done. I'll just separate the piece and just pull it with just vacuum. So I'm on pedal 2, vacuum aspiration, and I just take out the piece and then I emulsify it. So it's that easy. And I don't have to chop really deep. The cuts have gone well into the posterior part of the nucleus, and so the pieces are completely separate. So very easy and very ideal for premium lenses. So amazingly good. And then you can see that I have already done my LRI and won't even open it because it's the cut is continuous and smooth. LRI always works. And this I've implanted the latest addition to the Care Group technology, which is the Naturo panfocal IOL. It has no rings, no dysphotopsias, and it is a trifocal, which is pupil independent. So this is how the surgery goes with respect to cataract. So the advantages, basically, like I said, it has a brilliant CCC and effective LRIs, which are the two most important things which lack in any other femtosecond platform. Apart from that, I think everybody knows all the aspects of a femtosecond laser. Now, what the future holds in store for us is a faster cut for clear with reduced cutting time and a smoother cap cut with lesser overlap, which is going to further decrease the energy and time consumed and further improve our results. And also in the works is the Galili workflow integration, so that we won't have to mark manually, but we can just capture the image on the Galili topographer and transfer that image directly to the Zemer Z8 machine. So this is just a research case that we did during the development phase, and you can see that it has a different anterior cut, and so it has a much smoother anterior interface, and this is the anterior pass that is happening in green animations, and you can see that it has a broader scan beam which works much faster. And if you look at the interface, you can see that it's virtually no bubbles at all. So that's the end of my presentation. I'm happy to take any questions.
One thing I want to ask you, what is the incision size? So it's safer to extract the lenticle when you are doing that?
Sir, I am currently doing a 2.2, but I think it depends from your when you begin doing a lenticle extraction, I think it's better to have a at least 3 mm size so that you don't do cap tears. But once you've developed the muscle memory to, just remember the fulcrum is at the incision, and you've learned how to dissect on the side of your dominant hand, basically, then you can reduce the size. So it's completely depends on you.
This machine is an advantage because the laser application is really customized according to depth of the cornea.
Exactly.
That is the main advantage of this machine over others.
So this is this I showed you a very simplified thing to understand by example, but it's actually a constant change from the periphery to the center. It's not like stacked that it's done manually. It's a delta that is directly proportional to the depth, which is the best possible way to customize energy delivery.
Yeah,
that is possible.
That is the advantage with this machine. Thank you.
No, sir.
So now,
sir, sorry, sir. For clear?
For the surgery, which toric marking system you are using?
Sir, we mark on a slit lamp.
No, but on the microscope you have some attachment, which was showing the toric marking on the cornea.
No.
No,
That
okay.
is done on the slit lamp. So
Yeah.
we do basically to compensate for cyclotorsion,
That's okay, huh?
you have to have
In setting
a
for-
marking done, or you can have an integrated system like a IOL Master with the Zeiss
Yeah,
microscope.
okay.
But I don't have a Zeiss marking system. So I do a manual marking on the slit lamp, and then when I shift the patient into the OR, the machine automatically detects the GV marks, the gentian violet pen marks,
Okay.
and it aligns itself on those marks.
Thank you, Doctor, for a nice, wonderful talk. Now I will like to invite Dr. Miguel Morcillo, and he will be talking regarding my experience with IPCL.
No,
Go on.
we have just started using the IPCL models because I want to talk about my relationship with FACIP IOLs. Started as early as 1999 when we started to implant the ICL, the first models. Also, I worked in what is the biggest eye clinic network in Spain, and so not only myself, my whole group, we were the #1 implanters of ICL that time, and we passed for the first stages of the first models of these lenses. The reality is that the experience is excellent with excellent results, and I have only to remind myself 2 exchanges of lenses for excessive bolt and few explants for cataracts coming from other patients. So also we experienced some intraocular pressure issues with the first model that doesn't happen with the last model, and honestly it was a very good experience with no surgical complications and high patient satisfaction. This is clear, okay? But I would like to, I was very curious, and I always heard about the IPCL that seems to be just last launch in UAE, so I got it available, okay? Of course, this lens is also shown very excellent results, and there are many papers that show, especially comparing with the ICL, which has been for a long time the gold standard for this kind of lenses. But if you can do any search, you can find that clinically both ICL and APCL are effective methods and with comparable results. So the lens is showing great performance. Okay, these are the another references, published references. Okay, of course, this lens also shows a competitive price. I don't want to tell about cheap price because it looks like it's compromising the quality of the lens, which I find very good. So it's true that another reason for the implantation of this lens, it could be if we are looking for a more competitive price. And one thing that I find very interesting is the wider product range, no? Which ranges in spherical power from +15 to -13, and with also manufacturing cylinders of up to 10, which for me was very surprising. But the cases that I have done or also performed my colleague Dr. Marta in another clinic in Dubai are really very encouraging. And moreover, it's adding one thing that I always was telling the people from ICL in Spain is to add a presbyopic model, so as we don't have to remove the lens in many patients, especially myopic, and these lenses also provides. So if we say, which is better? Well, in this case, for me, what the concept that we were discussing yesterday is that IPCL, because of the more range in jumps in size, can be quite more or less tailored to the patient's eyes, no? Not only because of the wider range and of powers, but also what I like a lot is the wider range of sizes that can make the lens more customized. And by the way, the experience I have by now in my cases, all the balls have been very good with no issues. This lens also avoids, for very high myopic cases, the necessity of bioptics, which is required when you are using ICL. 1 year ago, I had a case, remember, minus 23. I had to implant only the lens, the ICL available at 218, and then I had to do a bioptics, and also many cases in Spain with this lens. This second surgery and delay satisfaction for the patient is fulfilled. And one thing I honestly like a lot is the horizontal implantation of the lens. Using the ICL toric models, frequently I am sent the implantations plans where I have to implant the lens 7 degrees, 11 degrees, which honestly, if you have a Callisto system, it can help. But in my experience, sometimes the Callisto system in the microscope fails. This is true. And also the Marks 11, usually the slit lamps have from 10 degrees jumps or 15 degrees jumps, which makes more difficult to get a precise alignment. In my experience, I have few post-operative astigmatic remains that I had to enhance with a LASIK or PRK. And this concept, I find it very, very interesting. Also, another thing that you hear frequently, but is not a big deal, although I had very few cases with big problems with the night halo due to the central hole, the concept of the conic structure of the hole instead of cylindrical. No patient by now, and it's short experience, of course. Dr. Kapoor and many of you colleagues probably have more experience than me. I have no patient complaining or telling me, I don't ask, but they didn't tell me nothing about the night halos by now, which I find it also interesting. And one, not medical, but very important in terms of getting the patient satisfied, is the fast delivery. Okay, the truth is that in Dubai, we have fastest delivery with and service from the IPCL. So all that things honestly has made me a little bit fall in love with the ICL and maybe cheat a little bit with the ICL. I would like just to add a video about the few cases. One thing I like to point out is that the charging the lens it's more simple. It's like any intraocular lens. I will, or maybe faster. Should be all the video running. Anyway, the lens is coming on this display, and it's uploaded in a normal cartridge, and even with a smaller incision than the ICL, which make me not to need to open too much. So with these implications of the possible astigmatism induction. You don't need specific instruments to slide, as we did with the ICL, all the lens all the way in the tube until we get the lens trapped in the small portion of the tube. Here you simply make sure not to get the lens well in the loading area, and then you simply click and close. And the attachment of the cartridge into the injector is very easy. I like to see that the pusher is not sliding on the lens and the lens moving normal. The surgery is, I like to do all the horizontal marks. I like a lot because horizontal marks are very easily to implant, to mark, even without a slit lamp. Honestly, you can see the horizontally, and I do on a slit lamp, but even if you don't have a slit lamp, you can do horizontal marks very easily. I use the same knife to do both incisions. I use intracameral and anesthetic. Filled with viscoelastic. Then during the implantation of the lens extends and spreads, and the first thing you have to check, because this is for the surgeon's position, is the notch in the side of the lens. In this case, the bubble was obstructing my vision, but when you see the notch, you simply let the lens to spread, very easy. One characteristic of the lens I found is compared with the ICL is softer. You have to, with the ICL is a little bit tighter, no, in the manipulation. You have to go very close to the haptic zone to slide it down. Okay, with the ICL maybe you can move a little bit further, but I think this doesn't create any issue. Finally, I like to do a gentle pressure to slide the viscoelastic outside from the lens to decrease the amount of viscoelastic in the trapped. I would like to make the video forward, but if not, we will start again, because I want to show you one little problem I had during the implantation of one of the lenses. Well, you finally remove the viscoelastic. You see the centration of the lens with the alignment of the marks with the Callisto system, and the marks in the sclera. It's perfect, and the lens goes to the natural position. We check the incisions and check manually the pressure. Here another case where we can see a perfect alignment of the marks of the lens. Always remember to see the two holes on the periphery of the optical zone towards the surgeon. And checking the final incision, I like to do this little maneuver, pushing softly just to make sure the incision coapts and closes perfectly. Okay. And now I think it's coming, but yes, during one of the implants, maybe it was my mistake because I didn't put the lens properly in or maybe it turned. That the question is that the lens came out a little bit in a mess. No, I tried to guess what was the position of the lens, and when I realized that the lens was upside down, I tried to move the injector, but finally the lens get into the eye upside down.
Your time's up, Dr. Miguel. Please try to finish fast.
No, this is it's fast. Just to see how do I flip the lens, and that's it. Sorry, because I wanted to make the video faster, but I don't know why. We'll start again. Okay, you see the bad position of the holes, and the lens is like this. So simply with two-hand technique, you get any manipulator on the side port, and you will see how smooth and fast the lens. We can flip the lens in the right position. The truth is that the patient didn't have a special corneal edema the next day. The recovery was very fast, and you can. When I had to do this with the ICL, you see the ICL is more rigid. This lens is softer and allows this maneuver more easy with a certain care, of course. Okay, and that's it. Sorry for the delay, but my plan was to make it faster.
And I think that inverse positioning of the view, and you try to flip it upside down again. So I'm telling you, it will never happen if you do just inject and 2/3 and just wait for 30 seconds. It will unfold. Then you see the position of holes, and then it's push. Because sometimes surgeons are rushing to just inject the lens, so it's become. So in my last 500 cases, there was no inverse positioning oil, so I have to reverse it. And the one advantage in IPCL over other phakic is that in toric, particularly toric cases, you have to you have just put 0 180 degree. That is a big advantage over other phakic IOL. and the 3-foot pad is the other advantage. But the big advantage in toric cases, in all lenses, just put 080. In no other lens in the world is featured same like this. Thank you.
Is the lens comparing with ICL thicker or thinner?
Technically, I cannot tell if it's thinner or thicker. What this is, the ICL is more rigid. This is softer.
When it is transported in the crystal bag, it is thicker, but over time it slightly thins when it is in the aqueous. This one, it shrinks slightly. Yeah.
It shrinks, yeah.
And you measure with the caliper?
With the caliper and with the pentacam. I send these two measurements.
Because my cases are going post of 9 years, 10 years, I don't find any difficulty with this lens comparative to other. Thank you.
Thank you very much.
Next, I would like to call Dr. Abhishek Chandra. Please come, and your talk is regarding my experience with Schwind MRIs.
So very good afternoon to all of you in the post-lunch session. Good afternoon, Dr. Mazhari. Thank you for inviting me for this workshop with the CARE group. So I'd just like to give a brief overview of my early experience with Schwind MRIs. I've been using this platform for the last 6 months now, and I'm quite happy with this. So just to give a brief outline, what is a conventional LASIK? In conventional LASIK, we first give 2 marks usually by junction wallet stain. Then we apply a suction ring. A flap is created by a microkeratome, and the flap is lifted. And then we put the excimer laser, and then we reposit the flap back. So that is a normal LASIK what we are doing. In PRK, what we do is we remove the epithelium either manually or with the help of alcohol, and then we apply the LASIK. So what is transepithelial PRK? Basically, it's a misnomer because actually it's not going through the epithelium. Basically, we are removing the epithelium also and the anterior part of the stroma with the same laser. It may have a different wavelength or it may have a different setting, but it is the same laser which removes both the epithelium and the anterior stroma. So what we do in transepithelial PRK is that we focus the cornea and then we just press our foot pedal. So the laser first removes the epithelium, and with a different wavelength and a different tone, it removes the anterior stroma of the cornea. Then the cornea is washed thoroughly. We apply mitomycin C depending upon the power of the refractive error, and then we place a bandage contact lens, and the surgery is over. So let me tell you that transepithelial PRK is the most easiest surgery in ophthalmology. You don't have to do anything. You just have to focus, put your foot switch, do the laser, apply mitomycin C, and put a BCL. So it's one of the easiest surgery in ophthalmology and very rewarding surgery. So as I told you, the excimer layer removes the top layer of the cornea epithelium and the stroma in one step, and it reshapes the corneal tissue below and corrects the refractive error. So the central epithelial thickness is usually 50 to 55 micron. So with the epithelial mapping, you can exactly measure the epithelial thickness and you can remove the epithelium. The peripheral epithelial thickness at 8 millimeter is slightly more, that is around 65 microns. So it is on the Schwind platform that you can remove the amount of epithelium and stroma depending upon the thickness of the epithelium. And everything, both the epithelium removal and the stroma, is in one go. So you don't have to do it twice as in other machines. So this is just a cam profile of PRK and trans PRK in myopia, where you can see in trans PRK it is much smoother in trans PRK. This is in hyperopia. So this is just a video. I think it's not working. They just copied it. It shows that is a very simple procedure. You just need to focus it and do the epithelial removal along with the stromal removal. So now coming to the main thing, what is all about LASIK? Any surgery, the surgery is usually not difficult, but the complications to be managed is the most important thing for any surgery. So if you see the complications of conventional surgery, usually most of the complications are related to the flaps. So if you take the complications of microkeratome related flaps, it can have a flat buttonhole, it can have a free flap, it can have an incomplete, short or irregular flaps, then there can be wrinkling of the flaps, there can be a corneal perforation, and even if with femtosecond, there can be a vertical gas breakthrough, anterior chamber gas bubbles, rainbow glare, other things. So coming to the post-operative complications, there can be an overcorrection or undercorrection that can happen with any LASIK machine. There can be visual rehabilitation. But most important, there are a few things which we more likely see in cases of a microkeratome-assisted flaps. That is, you can have a flap fold or stria. That is known as microstria. You can have a flap dislocation post-operatively. You can have a very severe dry eye, especially if you have not taken care in the early period. You can have a DLK or diffuse lamellar keratitis. There can be a pressure-induced stromal keratitis, central toxic keratitis, infectious keratitis. Then one of the very important thing is epithelial ingrowth, which I have seen in many patients, that after some time the epithelium grows inside the flaps, and then you have to either reposit the flap and clean it over, or you have to just wash it, and sometimes it recurs again. There can be ectasia, and then there can be very rare complications such as retinal detachment. So one is, if you have missed the holes or tears in the periphery preoperatively, then you are more prone for that. And second thing, what happens when you are using a microkeratome, you for making the cornea tight, you have to increase the pressure very high, and then you suddenly decompress it. So sometimes what happens, due to this increase in the pressure and decrease, sometimes there is a PVD induction, and then can lead to a hole. Sometimes in very rare conditions, it has been reported that this procedure has led to CRAO and CRVO with complete loss of vision. So I would say that LASIK is a very, very safe surgery, but still there are some amount of complications usually associated with microkeratome. Now coming to problems with transepithelial PRK, intraoperatively usually there are no other complications except that you have to focus it well, feed the power nicely, otherwise you can land up in a mess. Then immediate post-operative, there are two major problems with transepithelial PRK. One is the wow factor which you get in LASIK. You may not get immediate wow factor because for 2 to 3 days the patient is having a BCL, and there can be a slight pain or redness, and for the second and third day there can be a slight blurring of vision by the time that there is epithelialization of the cornea. Then there can be watering, decrease in vision on the second and third day, and usually by day 7 or day 6 the cornea is fine, the epithelialization has taken place, and the patient is very, very comfortable. Then the other complications are, there can be overcorrection, undercorrection, visual aberrations. There can be dry eye, but it is usually less severe as compared to a LASIK because you have ablated less amount of the cornea and the depth is usually less with the same power. Then there can be a corneal haze, which is reported, especially if you are not using mitomycin C. But with the newer LASIK techniques, with the micropulse technology, the haze is less and the healing is better. And if you're using mitomycin C, in very, very few cases you are able to see the haze. Otherwise, there is absolutely no haze after the surgery. So then there can be infectious keratitis, but it is much less as compared to a LASIK surgery. Ectasia is usually less because the stromal residual bed is much more in comparison to LASIK, and the chances of retinal detachment is much less. So just to conclude, the advantages are it is much safer, easier surgery to perform, only one-step surgery, and it can be combined with aberration-free corneal wavefront or contura or ocular wavefront, and it can be combined with Presbymax, which is for presbyopic correction, and no alcohol is required. So there is disadvantages which I told you was no wow effect initially, but usually in around 80% of the patients do not complain, because once you put a bandage contact lens, usually the pain and other things do not happen. In very few patients this does happen, and then you have to counsel the patient. And in very few patients, it's very difficult to predict, but there has been reports of mild subepithelial haze, which is there with any kind of PRK, but usually this is very less. And in the initial period, there can be a pain, discomfort, and watering in some patients. So just to summarize the advantages of Schwind-MRIs, it is a quick lasering with short treatment times, sophisticated eye tracking for safe and precise treatment. It has the fastest eye tracking system so as to get better results. It has smaller laser spots as compared to other machines with smoother interface and ablated epithelial margin for faster epithelialization. For example, once you do a PRK, the epithelialization will take a little long as compared to the transepithelial PRK because the area is short and there is a smooth area, so that the epithelialization from the normal cornea to the deepithelialized cornea is faster. And there is a more gentle tissue removal through thermal control in Schwind-MRIs. So this is smart pulse technology, which ensures that it enhances the short-term outcomes or the wow effect. It reduces the residual roughness, which is the most important feature. It improves the smoothness of the residual bed and without compromising stability or long-term outcomes, including aberrations in the refractive patients. So this is an electron microscopy. On the right-hand side, you can see that the surface is smoother as compared to a conventional laser. This is the clinical outcomes. So just to summarize our experience in the last 100 eyes, so 98% of the eyes have achieved 20/20 vision. In 92%, there was uncorrected 20/20 vision, but all eyes achieved, it is 20/30 vision at the end of 1 month. There was a minimal subepithelial haze was seen in 2 patients, but that did not affect the visual acuity. 3 patients had severe pain for the first 3 days and then it subsided. And there's one thing which I wanted to have the opinion of the audience. In my study, what I found that 36% of the patients had a high IOP in the initial period, more than 30 or even more than 40, which is usually the steroid responders are usually 10%, 8 to 10%. But in my study, I found that it was really high, maybe because the epithelium is not there and there is an increase in the drug penetration of Predfort. I'm using Predfort. Many people use L-Pred. But in this study, what I found that the pressure was relatively higher. But with medications, everybody was controlled, and after 1 month, we had to discontinue the anti-glaucoma medication. So to conclude, transepithelial PRK is safer, easier, faster, with low complication rate. And this is my hospital where we are working, and we are organizing the annual Eye Bank Station of India meet on 30th September and 1st of October. So those who want to come, you are most welcome for the meeting. Thank you very much.
There is a definitive advantage of trans PRK over PRK is that is a single step process.
Yeah.
But I prefer PRK over trans PRK because epithelial thickness is not uniform. And if you are keeping the epithelial thickness 60 micron and you will see the all epithelial map, you will see it is going from 52 to 62 kind of thing. So if you are applying the uniform laser, just removing the 60 micron, there may be surprise of.
No, sir. So in this case, what do? You first do an epithelial mapping.
Yes.
So you know exactly what is the epithelial light. And with the Cirrus 2, this information goes directly into the laser machine. So it removes exactly what is the epithelium thickness, so that there is no discrepancy between the epithelial thickness and what you are removing. So in that way, it is not a major problem.
Number 2 is the haze, post-op haze.
Yeah.
Haze is mainly because the post-op tapering of steroid is if you are very fast, not adding cycloimmune.
Yeah.
And lubrication is not adequate. Mitomycins definitely give advantage over
Yes.
that. But the most important challenge is the post-op 2 to 3 months, how we manage your case.
So that is why most of the people are using L-Pred, I think, in PRK, but I still use the Predfort only.
I first used dexamethasone for 4 weeks, then I shift to 1 month more for on L-Pred.
L-Pred.
With cycloimmune.
Yeah. So I usually go with Predfort for the first month in a tapering dose, and I have not seen much of a epithelial haze.
I avoid first Predfort in the first week because sometimes because it is sticky, you have application of BCL, sometimes fold it down. Patient
but
I go.
You can see the white dots, but actually it doesn't hurt the patient.
Yes, I know. Thank you, Dr.
So thank you very much, sir.
Now I would like to invite Dr. Amit Mahajan, please. He will be talking regarding acryol AC toric lens.
Good afternoon, everyone.
Harsh.
At the outset, I would like to thank All India Society and Care Group for giving me this opportunity. I don't have any financial disclosures. So this is a well-known fact that astigmatism not only reduces the visual quality, but it also hampers the depth perception as well as the quality of the vision. 30% of the eyes, they do have astigmatism of more than one diopter. Either you do LRI or you do OCCI, nothing is as precise, as accurate as like a toric lenses. But at the same time, even slightest of the rotation, like even 10 degree of the rotation, can also cause 30 degree loss of the total astigmatism correction. So I would like to share this one interesting study in which 95% of the surgeons, they do agree that clinically significant astigmatism has to be corrected at the time of the surgery. But 73% of the surgeons, they even do not attempt to correct it at the time of the surgery. So what are the main hurdles that I think in the toric implantation? So the first and the most important is accurate pre-op assessment. There are so many variables like keratometry, axial length, accurate formula, and all those things, they lead to confusion. So we are not sure that our pre-op assessment is correct. Even though we are sure that we got accurate pre-op assessment, then while coming to the implantation of the toric IOL, again there are so many variables like which marker, sitting position or lying down position, marker or like scratch mark or anything that leads to confusion. Even though we get accurate pre-op measurement, we got accurate bang on IOL in place, but then we are not sure about the rotational stability. So all these are the main hurdles. So why I was not so keen for the toric? So mainly because of so many variables like keratometry, what I have told you, that keratometry, axial length, formula, markers, sitting position, lying down position, everything, and that all leads to the confusion. So is it the only factor that was preventing me from going to toric? No. The main factor was the affordability. As most of the multinational companies, they do have accurate toric IOLs, but that is beyond the range of me and my patients. So the main concern was of the affordability. When it comes to some Indian companies, they have come up with the excellent solution. But again, there is the issue of consistency and predictability. So here I found Acryolici toric more consistent and more predictable. What is the most important thing, I think, is the proven Acryolici platform. I don't think that there is any surgeon from Srinagar to Port Blair who have not used Acryol EC lens at least once in his life. So it is a more proven platform. It is available from 0 to 30 spherical, from 0 to 6 cylinder. So it covers the whole of the range. And the most important thing is the tackiness control technology, with which the posterior surface they have treated such a way that there is a less PCO and that posterior surface adheres to the PC, and that prevents the rotation. So let's go quickly to my experience. For this particular study, I have considered 180 patients who are having cylinder of more than one diopter. All the biometry done was on IOL Master 700. Formula used was Barrett. Again for toric calculation, Barrett was used. So this is the short video in which I would like to show you that Barrett calculation is not a big deal. It is easily available on the Google. You can Google it for the Barrett. Once you have Google it, you can get it free from APCRS website. In that formula, you have to just enter your doctor's name, patient name, which eye, right or left eye, steep K, flat K, axis, ACD, W to W, and that's all. Many of the people, they hesitate going for the Barrett only because they think that Barrett is not incorporated in my ultrasonography machine or my optical, then how can I go for it? So this video is only for them. It is only 30-second video in which you have to just fill the everything data, and within a fraction of second you get it. So within 30 seconds you get accurate toric power and toric placement also. So this is my short video in which I will show you how to implant Acryolici toric. I won't go into the details, but cortical cleanup is something which I feel is a more important thing, because unless you left some cortex, that will lead to fibrosis and rotation. Second more step is the proper IOL loading. The IOL has to be loaded under actual visualization under the microscope, and make sure that optic and haptic are free, just like as in the cartridge they are freely moving. I always prefer hydro implantation. This is a hydro implantation of Acryolici. I just want you to see how easily it goes inside the bag. Nothing, no visco is used. It is going very smoothly. Once it is inside the bag, you just cross align the IOL, remove the traces of the visco. Even if you implant it hydro, just go behind the lens and remove the whatever OVD is remaining behind the lens, and then you have to do the final alignment. So first gross alignment, remove the OVD from behind the IOL, and then final alignment. So this is the final alignment. I will just skip. So these are some of the pictures which are showing how exactly or how bang on this IOL sit on the axis. This is a Callisto measure. If you have it, then nothing like it. But even if you don't have it, you can do it manually very well. There are few apps like Dr. Saurabh Patwardhan's Toric Patwardhan app, or Dr. Swapnil Kothari has invented one precise toric calculator app. I don't have any financial inclusions, but these are very effective and very useful apps. But if you have Callisto, then nothing like it. So regarding post-operative examinations, I have checked the axis placement on eye tracy, and as you can see, there is only 3 degrees of rotation. That means the IOL is bang on. It is sitting bang on the axis. Regarding post-op uncorrected visual acuity, nothing was special. But what I want to draw your attention is, you can see that in 70% of the patients, the rotation was only 0 to 5 degree, while 5 to 8 degree was in remaining 16%, and only in the 14% it was having 8 to 10 degree. What I mean to say that in all the cases, there is no one case in which it was more than 10 degree rotation after 6 months of post-operative period. So suppose we want to realign the toric IOL. You just have to wait for the 3 weeks. And after 3 weeks, if you feel that it has to be redialed, then it is very simple and accurate. Go to www.astigmatism.com, or you can take help of the eye tracy. Just for the sake of showing you this case in which eye tracy, it is showing 69 degree of rotation. So this IOL has to be rotated. So you can select like this, and how and where, that is also shown on the eye tracy. This is the green axis which is showing the intended axis, while that is blue line that is showing your actual IOL where it is sitting. So if you have eye tracy, you can go for it. So to conclude, tips for the successful and predictable outcomes. So regarding biometry, I will like to recommend one man, one machine, and one technique. This is not like that today you are taking K readings from autoref, tomorrow from your optical biometer, day after tomorrow from pentacam, or like that topographer. No, it has to be one machine that has to be customized. Again, technician, either you or technician has to be the same, because we can customize. And again, technique. If you are using Barrett, go for it. Not like that today Barrett, tomorrow SRKT. So one man, one machine, one technique, that will save you biometry. Regarding SIA, with the concept of centroid SIA, now it is a well known that SIA doesn't only have the magnitude, it has got direction also, vector also. So please calculate centroid SIA. And with the advent of this centroid SIA, most of the surgeons doing 2.2, they have got their SIA is 0.25 or even less than 0.25. Gone are those days when keratometry is only K1 and K2. Now with so much of talking about posterior corneal curvature, one has to actually calculate it by like machines like Pentacam or IOL Master, or you just have to fill all the data to the Barrett, and that will take care of the posterior corneal astigmatism. But don't forget about posterior corneal astigmatism. Barrett, forget everything. When it comes to the toric, only Barrett and Barrett. Rest, forget about everything. Regarding that reference mark, either you do it in a sitting posture or in a slit lamp, I would highly recommend don't do it with your marker, because ink can fade, it can spread, or by the time you take the patient to the OT table, it may vanish. So I always recommend to do a scratch mark. Regarding rexis, it has to be central, 5 mm. If not 5 mm, then at least it should cover 360 degree of the optic, ideally. But somewhere, if you think your rexis is elongated, doesn't matter. You can put safely toric lens. What if your rexis get extended? At that moment, you have to be sure that your toric IOL is going to sit inside the back. Then and then only you implant. Otherwise, don't go for the toric. Like one aptic in the back and one aptic in the sulcus. No, that is not the ideal position for the this. Regarding OVD removal, this is a very small and short video.
Little
But for the sake of the time being, I will skip it. But the only thing that I want to emphasize, whichever technique you implant, but with the irrigating cannula, you just go behind the IOL and remove even traces of the OVD that is remaining. Ensure proper positioning even after removal of the speculum, because in topical, when we remove the speculum, most of the times patient blink vigorously. So ensure that IOL is proper in sitting. And this is what I recommend you, that after doing surgery, ask the patient to lie down in a supine position with closing the eyes for 1 hour, because most of the time that rotation occurs in first hour of the post operation. So ask him to lie down, just close your eyes and supine position for 1 hour. Again, minimum medications and avoid eye rubbing. So there is no shortcut to the torics. You have to learn from your own mistakes, you have to work hard, and you have to implant the torics. Unless and until you implant toric, you cannot recognize your results. And once you recognize your result, then there is nothing wow like a toric. So practice makes the toric perfect. Thank you.
Oh, thank you. Regarding the actual EC toric, it is relatively very stable lens. When you place, is very stable. When I compare with other lens,
Absolutely.
I found it very stable.
Absolutely.
Very rare rotation we found.
Exactly, sir.
Yeah.
Exactly. It's a very stable lens, very easy to implant. You can implant to 2.2 also.
Okay, thank you.
Thank you. Thank you.